Welcome to Taking Charge of My Cancer Podcast, episode 21. I am Dorly Munoz, your host, and I am so excited to have this conversation with an amazing colleague and researcher, Cheryl Brunelle. So Cheryl is an associate director of the Breast Cancer-Related Lymphedema Research Program and a clinical specialist in physical therapy at Massachusetts General Hospital in Boston. She earned her physical therapy degrees at the University of Toronto, Canada, complete her lymphedema certification with doctors Albert and Olivier Leduc in London, England, and with Klose Training in Boston. Her clinical focus is oncology program and staff development with the General Massachusetts, or Mass General, Department of Physical and Occupational Therapy, and the evaluation and treatment of patients during and after breast cancer treatment for issues such as surveillance and early intervention for lymphedema, shoulder morbidity, and deconditioning resulting from breast cancer and its treatment. She's a strong proponent of lymphedema screening, a standard of care for patients treated with breast cancer. Since 2005, over 6,800 women has been screened for lymphedema after breast cancer treatment with Mass General Lymphedema Prospective Screening Program. She joined the Lymphedema Research Program in 2014, and since which time she has published over 25 papers, has collaborated on multidisciplinary teams to update hospital policies, including recommendations to receiving the COVID vaccine after lymph node removal for breast cancer, as well as collaborated on a recent white paper establishing measurement guidelines for lower extremity lymphedema in research studies. She presents the team's research works regularly at national and international conference. Cheryl's breast cancer-related lymphedema research interests include early intervention, measurement, effects of COVID vaccine after lymph node removal, prospective surveillance, precautionary measurements, and breast edema. And I can continue talking about the amazing work she does like for hours. So Cheryl, thank you so much for being here with us. I'm super excited to have you in this podcast.
Thank you. I'm so happy to be here. Thank you so much for inviting me. We go back a long way, and I'm just so happy to see you and be part of this. Thank you.
That's awesome. So will you want to tell us how did you end up in this mission? Just, being a PT and oncology.
Yes. So I've been a physical therapist and actually a certified lymphedema therapist for almost 25 years now. I feel very old. But I'm really fortunate to be in a position where I have clinical practice and research. And I think it's a very nice position to be in as a physical therapist because it's quite rare to be able to balance one's career with research and clinical practice. So it's nice because my clinical practice drives my research questions, and I'm very curious about some of the things I see in patients. And then in turn, my research, I can bring that right in the room and make sure that what I'm doing with patients is evidence-based, and it's my job to be on top of the literature and be able to answer their questions. And I hope they feel like I can, support them in that way. When you introduced me, thank you for that kind introduction. We are very strong proponents here of screening, and that is very much a big part of the mission of what we do here at Mass General Hospital. We strongly believe that every woman who has breast cancer should have access to screening. And this, there's so many recommendations now from national, international organizations that we should be doing this. Yep. And this should be standard of care, but most facilities still aren't. And I think in many ways, there's good reason for that. There are a lot of challenges in this healthcare system to starting a lymphedema screening program. The literature is not clear on how we measure lymphedema. We don't agree on how we measure lymphedema. We don't agree on how we diagnose lymphedema. So there are a lot of challenges, and I think I know our team wants to be a part of helping to mentor different facilities and different clinics on starting a program. We've learned so much as we've done this. This program started in 2005. We've actually screened over 7,500 women now. The Bible is a little bit old. But, we've learned a lot of lessons, and I think helping to mentor other facilities, or at least just support them in any way we can, so that we can see that screening becomes standard of care for patients, for women who've been diagnosed with breast cancer. We just collaborated with a team at Boston Medical Center You know, this is a facility who has the trust and the clinical rapport and serves communities of color. 40% of their population is Black. And those women present with much higher risk cancers, and they're at much higher risk of lymphedema.
Yeah.
And yet they're just going to publish their data now, but only half of women who had lymphedema in their population in their paper in the last few years were referred for treatment, and only half of those were able to attain treatment and go to their therapy sessions. So there are so many barriers right now, and if we have learned many things over the last 20 years and hope that we can share some of those, but to try to really ensure that underserved populations have equitable access to screening, and that every woman in every community should be able to access it as well.
Okay, thank you. And again, you've been an amazing like mentor in a way, like you always reaching out to you. I so enjoy every conference I go. It's just it's kind of like, sometimes you have people that come across that, they teach you something and you get the information versus you have the passion. And I have the pleasure to shadow you in the clinic just, last year. And that was amazing experience. That was super great to actually see you.
You and I learned, taught each other that day, and we learned a lot together. We saw some pretty great patients that
exactly day. So that was great. So you inspire me a lot in what you guys do. And even though I wish I'm in an institution that support more that research part, which I would love to be part of it, but I'm still always like seeking for new things, new information. How can we just be really on top of things as well where I work at? So thank you for that.
Well, I think you do that because when I hear you speak at conferences, your passion is palpable. And I see your name on the docket and I show up because I know it will be a great presentation.
Thank you. Were you always planning to do this?
No, not at all. So when I was younger, I loved sports and I loved science, and I did an undergraduate degree in human kinetics. And it was the university I went to in Canada, which is home for me, was very biomechanics based, very physics based, engineering based, and I loved it. And what I wanted to go into was prosthetics.
Oh, wow.
And making prosthetics and supporting people who lost limbs to surgeries or traumas. However, when I started doing my clinical rotations at the University of Toronto in physical therapy, I quickly realized I just loved being in the hospital, and I loved inpatient PT. And I loved the fact that I didn't know what was wrong with a lot of these patients, and I had to figure it out, and just being on the medical side of it and learning about labs and imaging and blood counts and trying to put that medical piece together, I found fascinating. And I wanted to really establish a good kind of baseline framework for my practice in the hospital setting. And I didn't actually work in Canada very long, just under a year. And I moved to London, England. And I worked in a little surgical hospital there, right on the Thames. It was beautiful. It's still there. And there were several surgeons there who did cancer surgery. So one was a breast surgeon, one did surgeries for patients with gynecologic malignancies, and one was a very, very amazing sarcoma surgeon. And so I got to go into the OR with them and see these surgeries, and at least half of the PTs at that hospital were lymphedema therapists.
Wow.
And lymphedema treatment really originated in Western Europe, right? In Germany and Austria with the Foldy Clinic and the Vater School, and Dr. Vater. And so they've been doing this since the 30s, 40s, 50s. We didn't see this hit this side of the ocean till the 70s, 80s, 90s. So they're really far ahead of us. And I didn't understand why everyone there was a lymphedema therapist. So off I went and did my training, and I started to see these patients, and I just fell in love with seeing these patients. Their quality of life went up immediately when you gave them the care they needed. They had the bandaging and materials coming from Germany even 20 years ago were amazing. And I just realized how much I love this population. And luckily, in the little hospital I was working at, I got to see patients before surgery, after surgery, in outpatients and at home. So I have to
Awesome.
do everything because we had to do everything. There weren't many of us.
That was
Um,
awesome. Yeah.
so I kind of fell into that. And then I moved to Boston and started at Mass General and kind of became the consult that people would ask, hey, this patient has swelling, or this woman had lymphedema after breast cancer. Now she's been admitted for something totally different, but how can we get her care while she's here? So things like that. And I quickly became that consult service. And it was very helpful on the medicines when I was on the medical service, because I could treat swelling of all different kinds of origins. And there's really a great place for that in hospital. And I wish more PTs and OTs were lymphedema therapists on the inpatient service. I think it would really serve the patients well.
Yep.
So then I moved to outpatients to this position that I'm in almost 10 years ago now. And it has been, I feel like I fell into this, and it's been a beautiful fall. I think I am where I was meant to be in my career. But this ability to direct the research program here with Dr. Tegan, and the ability to continue my practice as a clinical specialist in outpatients, it's just a really nice balance. It was not at all what I planned. But everything happens for a reason, and I feel like I'm in the right place, and I have a great mentor in Dr. Tegan and a great group of lymphedema therapists around me, young and up and coming and super curious and great clinicians. So I feel very lucky.
Excellent. Will be 3 valuable tips that you learn about your journey that you can share with the audience?
I would say, I think I'm around a lot of younger PTs who are not at all involved in research. And I would say dip your foot in. There's so much room for PTs to just get involved at any level they want. Join a SIG, follow the literature. If someone asks you to help out with a book chapter, go ahead and try. There's always someone around you can ask to mentor you, but just get involved. I would say explore opportunities rather than following your plan. I would be in a very different place if I didn't kind of just follow the road where it went and I went with my plan. Maybe it would have been good anyway, but felt very scary to make some of the moves that I did, but I think they turned out to be good decisions, great decisions. And finally, I think as one of the leadership here in the physical therapy department, a piece of advice I always got is to try to build a team with people who are better than you and stronger than you. Put in place people who are better than you and mentor them, and get a strong team and never be intimidated by the people around you. It takes a village to treat these patients. And we're so lucky here. I have hand therapists when my patient has a trigger finger. I have a neurologic therapist when my patient has a tumor in her brachial plexus and I don't quite know what to do that's the best care for this patient. So I really try to surround myself with great people and try to give younger staff opportunities to start in research and just dip their feet in. And some staff have taken to this as their passion, and I think they have unlimited potential. So those would be my 3 suggestions.
How about for cancer patients? What would be some valuable tips for as a clinician for these patients?
For these patients, I would say, unfortunately, patients have to be their own self-advocates.
Yep.
So a lot of times patients are being nice and kind and not wanting to complain and not wanting to say anything. I tell patients, tell anyone who will listen. Talk loudly to your PCP that you need help with whatever's going on, or you need to better understand whatever's going on. A lot of us in the healthcare world don't understand lymphedema. We just don't, and we underestimate its impact on patients. Quality of life is the problem with lymphedema. It's a huge emotional burden, financial burden. I don't need to tell you, cost burden. And patients do need to tell anyone who will listen. I think my patients tell me all the time, when cancer treatment finished, everyone around me thought I was fine. And I just was going to move on and move forward. And lymphedema kicks you in the shin after you finish treatment in many times. And I think they need to tell the people around them they're not fine. And this is really hard to deal with. And I need your support. And they need to seek out treatment as well. Also, I think they just need to understand that there's a lot we don't know. and that we're trying, but there's really a lot we don't know. And there are good resources like Lymphatic Education and Research Network, who are very, very supportive for patients to develop connections and develop connection to kind of what's happening in the research world that might help them and benefit them. And the other thing I would say to patients is, if you have a lymphedema therapist, first of all, find one who you trust. Mm-hmm. Find one who you know is giving you enough treatment. It's a big problem right now that therapists feel very pushed and very high pressure because volume is so high. Mm-hmm. It doesn't mean we give patients less. Mm-hmm. It means we might have to wait to see you, but we still need to give you what you need. Mm-hmm. So I think to be able to push, and if you feel like it's not a match, you need to find one who is a match and make sure you're getting quality care and speak to your team about it.
Okay. How about your most painful lesson and through your journey?
One of them was that I really didn't have a full understanding how much patients had to really do on their own. And I struggle with that still, that patients really need to advocate for themselves. And when I think about lymphatic diseases, I think about lymphedema. Mm-hmm. And those patients, I just met a patient a few weeks back who struggled for a diagnosis for 30 years.
Oh my God.
It should not be, right? That should not be. No. She should have had her diagnosis decades ago. And that puts her in a very different place emotionally, physically, than where she would have been had she been diagnosed a long time ago. And so I teach patients to really self-advocate, but I think that was a very painful lesson for me to learn, that we didn't do better by these patients. Yeah. Because we didn't know, and we didn't maybe make an attempt to know for a long time. Another painful lesson is that getting into the research world, understanding that lymphatic diseases are totally understudied, under-researched, and under-recognized. It's a battle to get financial support for our research, and I spend a lot of time writing grants and looking for money to fund research, many, many hours that could be spent doing something else like treating patients or contributing something to the literature. And finally, the third thing I would say is just till now, I think we're vastly improving now, but the quality of research, the quality of treatment, and the quality of measurement, quality of screening, I think quality in general, we are working on, but there's still so much we could do better. So I think we need to keep looking, within and realizing that there's a lot we could do better. Do not, as a patient or a CLT, read a paper and think that study was done perfectly. It's really hard to do a study.
It is.
And none of our studies are perfect. They all have limitations, but critique those for their quality and really learn how to read research papers so that you can draw from them things that you can bring to your practice that really truly are evidence-based.
Excellent. There is anything that you have that will be of value for our audience, and will you share that with us?
I think overwhelmingly something a patient told me when I was talking at a conference about quality of life in PT, and I asked my patients, what do you need? What is it that I could bring to you or that I could talk about that you need? And they said, tell me I have hope. Tell me about hope. And I thought that was so good. Wow. And I think that's what we can bring now. There's so much happening in this world. So I think first, hope that lymphedema education is finally happening. When you are learning to be a PT, an OT, a physician, you're now learning in school about the lymphatic system. Yeah. I've been doing a few lectures at the university level, and it's been so well received because it's something that we just didn't learn. I wish I would have learned that, right? Yeah. So I think hope that people around you are actually going to know more about this. And for your kids or for people with lymphedema whose families have been affected by this, hopefully we can stop the not knowing and be able to recognize these things. Hope that knowledge of lymphatic diseases is improving. Research is growing in leaps and bounds, and the NIH now has this commission for lymphatic diseases, literally devoted to lymphatic diseases, and funds being set aside for lymphatic disease research.
That's awesome. That's great to hear.
It's so much is happening, right? And hope that their garments can finally be covered.
Yeah.
The
I saw,
Lymphedema Treatment Act just passed, right?
yes,
This is a
I saw,
federal law now that
yes,
passed.
yes. Perfect. Yeah, I saw
So
that last week. Yeah.
I know. So this goes into effect January 1st, 2024. So there will be coverage for compression garments and supplies. And we know as lymphedema therapists, right, how expensive these can be. And these patients need to keep replacing them.
Yep.
So there will now be support for this and coverage for this. And finally, hope that there are surgical options too.
Mhm.
And there's a lot of research being done about surgical options. So in the past, you know this as well, there are just patients where we can treat them the best we possibly could, and we can't get their lymphedema under control to the extent that we would like. And now there's options that I can offer them for
Yep.
surgical reconstruction, which we never could have done. And I think we're in a completely different place now than we even were 5 and 10 years ago. So I can't even imagine where we'll be in
Yeah.
5 or 10 more years. I have a lot of hope in so many ways with
Yeah.
lymphatic diseases.
Yes. And a little piggybacking on that is just so nice to be able to tell a patient, when we have, like, I remember when we started doing our lymphedema transplant program with Dr. Singhol back then, 8 years ago or whatever. And I remember, super exciting doing all that. And then at that point, before that, we were telling patients, really, nothing else can be done, right? So you're just going to have to live like this the rest of your life. And hopefully you have less amount of cellulitis a year or just it's not going to continue growing. And then we did start the lymph node transplant program, and it's amazing how I've been seeing him growing over there, over Beth Israel, and doing amazing things that now is so great to be able to have a patient come in and say, I understand there's nothing else can be done. Like, no, it's a ton of things can be done. I want you to go see so and so, and it's so many options now. So it is great to see that turning. And
Yeah,
you're right, I'm so excited to see what's will be happening in 5 years or so about this.
absolutely.
How people can find you, and I will put your information on the podcast description, but if you can just tell us a little bit, like, how can they find you?
Well, so I'm at Mass General Hospital in Boston. So we are on Twitter. Our lymphedema program's on Twitter. It's at lymphedema MGH. So they can always check us out on Twitter and send a message, and that will get connected through to me. We have a website that if you Google MGH breast cancer related lymphedema program, it will pop right up. And that will show you, who our team is, what we do. It has links to all the research that we've done and our papers. And if you'd like to send a message through to the program that way, that will also get through to me. And I'm here and not going anywhere. So I'm pretty easy to find.
Excellent. Excellent. I wish you were a little bit closer to Florida.
Oh, sometimes I wish I was closer to Florida too, especially in January.
Yeah, exactly. How about books that you would recommend to our audience?
I think I talked to you a little bit about this. I really often just read to escape, or most of my escape is running. A little bit of running, and I don't often put music on or podcasts or any of that. And a lot of the reading I do is lymphedema journals and research. But one book that I just connected with, I actually read it a long time ago, was A Man Called Uwe, which was made into a movie here, A Man Called Otto, with Tom Hanks. And the book was way better than the movie. I read it a long time ago, but it's a Swedish book, and it's a really nice use of dark humor, and it's heart-wrenching, the book. If you haven't read it, I would say read the book, don't watch the movie. Not that the movie wasn't good, but it's about relationships and understanding that when people are at their worst, that's when they need people the most. Even people who feel uninvited. Insert yourself, knowing that somebody needs you. And it's the little things, a little kindness, a little perseverance goes a long way. And I think the message of this movie at the end was one person, even though he didn't realize it, had a dramatic impact on a lot of lives. And I think it's just a nice book about connection and the importance of that, and that all hope is not lost. You can connect. And the other book I go back to, which is going to sound kind of funny, but Foldy's textbook of lymphology is the same. book, I would say, for CLTs, probably not so much for patients, but the deeper I get into research and patient care, I still have to go back and review my anatomy
Yeah.
and review the basics and think about, why are we doing this particular garment? What am I physiologically, achieving? Or when I'm doing my research, going back to the physiology and the anatomy is just really helpful. And as lymphedema therapists, I think we should go back to the basics a lot more than we probably do. We need to find time to do that. So I do still love that book. It's one of the few that still sits above. There's very little paper in my life, but that's one that sits right above my desk, and I grab it often.
Okay, perfect. How about movies?
So I really, really watch movies to escape. And I have 2 boys. So the depth of the movies I've watched recently is not deep. And I will tell you, I went and watched Mission Impossible on the weekend. And it's great because it was a great escape, right? It was pure fun, pure escapism, and time with my 2 boys, which I covet. So anything they like to watch, I generally do too. And that was my most recent one. But I would just encourage, again, we all work so hard, right? And patients just have tough, long days with treatment, and we ask a lot of them, just escape with their movie.
Exactly. And no matter what kind of movie, if you like comedy, if you like horror, if you like romantic, if you whatever works. I was talking with somebody else yesterday, and they talk about like what is it, the blonde, oh my god, I forgot, what's the name of this movie? Oh no, she's I'm so bad with names. No, she's like a lawyer, blonde.
Legally Blonde, is that one?
Yes, that one. That was like so much fun. I was like just laughing about it because I love that movie. It's so funny.
That is a total escape. Yes.
That's a total escape. Is there any question that you wish I would have asked you, and would you have answered it?
The only thing I think is maybe tell me about a project you're excited about right now in the lymphedema world. And what I would answer is that a big part of what we're doing now is working on breast edema. And it's something that, I've struggled to care for over the time I've been treating lymphedema, and we know so little about it. Yeah. So for women who have a lumpectomy or partial mastectomy, a lot of them go on to develop this breast swelling. It's not just post-operatively, it lasts a long time in many women, and it's very symptomatic. It's very bothersome. So I'm really interested in learning more. We have some studies on it, certainly in the literature, but learning more in a very current cohort, what causes it, screen for it, look for risk factors, figure out how to treat it, help patients understand who's at the highest risk, and try to figure out what we should really be doing about it. So that's a project I'm really excited about. I just finished writing a grant, just submitted to the NIH, so cross our fingers, on June 5th.
Amazing.
So that's been my reading the last 6 months. But we're really excited about that project because it's one that impacts patients a lot.
You're
who
right.
have breast conserving surgery, and they don't see it, again, like lymphedema of any kind. They just don't see it coming, and it's bothersome.
And I'm so happy that you are mentioning that, just because it's another part as well, which I'm sure you're being challenged, is how do we measure that, right? I ask that on every conference I go, like I've been asking that to Julia Osborne, like everyone that does a lot of lectures is like, how do we come up with a good way objectively to measure breast lymphedema, right? Or trunk lymphedema. And so I'm excited you actually diving into that, because I'm totally agree with you. Like, you do all these other, rib cage pumps and mobilization and manual drainage and doing all those things and all these new pathways that now we are moving into, right? Versus the typical anastomosis. We were doing a lot of things start changing so much based on Australian research, but I'm so excited you're doing that, because it's a lot of things we can really learn from what you guys get on research for that. So that's great.
And not just for patients with breast cancer. I'm seeing a patient right now who had lung cancer.
Yep.
And had lymph nodes removed with that. And she developed truncal lymphedema just on one side. And so again, like you said, we're throwing everything at it and using everything we can. But a lot of those patients with thoracic surgeries end up with trunk lymphedema, and we don't measure it well, and we don't really know how to treat it well. So we throw everything at it, but that's very time consuming for patients. It would be nice to know exactly what we should be doing.
Exactly. Well, that has been so much fun, Cheryl. Thank you so much for sharing tons of great information. I'm so excited to have you here and to see you. I really appreciate you being part of this. Thank you so much.
Thank you so much for inviting me. It's always a pleasure to talk to you.
Absolutely. And you have a great rest of the afternoon.
Thank you, and you.
Okay, bye.